Okay, here we are, chapter 47, head and face trauma. There's a little over 200 and some odd slides, so I'm going to divide it up into two parts, and we'll get through what we can in the first part, I think all the way up to injuries to the eye. And then we'll wrap up with head injuries, because head injuries in itself is a lengthy topic. So we're going to start first with maxillofacial injuries. And I think it's important to keep in mind that when you have soft tissue injuries of the face, that because of the face's extensive blood supply, that there can be significant bleeding from a maxillofacial injury. The blood supply comes from right off the carotid artery and branches out into the superficial temporal, the mandibular, and the maxillary arteries. And you can palpate your temporal artery in the temporal region of your skull. So here's just an example of the arterial blood supply to the face itself. And as we had mentioned, that that can be quite extensive. The bleeding can. We also look at the nerves of the face as well. There's 4 cranial nerves that are involved in what happens in the face. You got the oculomotor nerve, which is the 3rd cranial nerve, and that, in addition to movement of the eye, also is responsible for your pupil's response to light. And we'll talk about head injuries, how when there's herniation or a rise in intracranial pressure, how that can put a little squeeze on that 3rd cranial nerve, causing a blown pupil. You've got your 4th cranial nerve, which is your trochlear nerve, and that nerve is responsible for the superior oblique muscle on the top of the eye that helps the eye stay upright and straight forward and raise the eyeball, that sort of thing, to look up. And if there's damage to that particular cranial nerve, what you'll see is an eye that will droop or look down, and they won't be able to pick it up. The trigeminal nerve is the 5th cranial nerve, and that nerve is involved in the sinuses, the teeth, anything to do with mastication, anything to do with chewing and breaking up food, the movement of your nares, nasal flaring, that sort of thing. And then the 7th cranial nerve is the facial motor nerve, and that's all the muscles of the face are innervated by that 7th cranial nerve. Then we start looking at the bones. You have 22 bones in the skull, 8 cranial bones. Essentially, there are 4 pair. You have 2 frontal bones, 2 parietal bones, 2 temporal bones, and 2 occipital bones. And they're fused together by the time you're an adult. But when you're first born, those suture lines are more commonly known as fontanelles, but they eventually do fuse together as you get older. And then you have 14 facial bones, or 7 pair of facial bones: lacrimal bones, nasal bones, ethmoid, sphenoid, and then zygomatic bones, and then the maxilla and the mandible. And the pair, of course, refers to left and right. Now, maxillofacial trauma can be the result of blunt trauma, penetrating trauma, or even a toxic exposure. And what you deal with primarily with maxillofacial injuries is soft tissue injuries. And because it involves the face, those injuries can be very distracting. If there's a severe maxillofacial trauma, the face identifies who we are and tells us a lot about that person. And if it's quite disfigured, we may have a tendency to get tunnel vision. But there often is maxillofacial trauma following motor vehicle crashes, definitely assaults or personal altercations, elderlies because of their increased risk of falling, and then airbags will even cause trauma to the face. As you begin your history and physical findings of these soft tissue injuries to make sure that there isn't a life threat, now you'll note the mechanism of injury, how did it occur, when did it occur, what sort of signs and symptoms are you seeing, and then get a good sample history, the allergies, meds, last oral intake, and pertinent past medical history. The events leading up to the injury, that's all part of sample. And it says ABCDs here, but that certainly would be one of the first bullet points prior to getting a sample history. The nice thing about our body is that we do have a left and a right side, and they should be symmetric. So one of the things that you're looking for when you're assessing for soft tissue injuries of the face is symmetry. Is one side of the face deformed more than the other? Are the eyes level? They should be level. They both should be looking forward and out. The eyes should be able to follow your fingers without turning their head. Those sort of things. The mouth corners should move symmetrically, and that's one of the things we look for when assessing for stroke. Have them give you a big smile, and both corners should move symmetrically. The nose should be straight and midline, of course, unless there's been a previous fracture of the nose. Just as you would evaluate for symmetry, you're also going to be looking for things that are asymmetric. Palpate the facial structures with both hands simultaneously. So palpate, both zygomas, palpate both nasal bones, palpate both temporal bones, those sort of things. Look in the nose, have them bite down to see if their bite is good. And if they've got any sort of facial nerve injury, then that's where you may get some facial droop. Now, facial droop can be the result of a stroke, but it also could be the result of an injury to the facial nerve following trauma, or in the case of Bell's palsy, just an inflammation of the track that the nerve slides through as it innervates the face. Deep cheek lacerations, you could be dealing with the parotid duct and the parotid gland and the facial nerve. And here you can see where the facial nerve comes right. The facial nerve is attached directly to the pons and comes out just below the ear, and then branches out in those different branches that you see. This is kind of a misleading sort of representation, because the yellow nerves that you're seeing there are by far very large nerves. When the facial nerve goes into the parotid gland, it starts to divide into tens of thousands of small nerve fibers that filter out from the parotid gland into the face. And here again they're talking more about the nerves of the face, the temporal and the zygomatic branch, facial nerve buccal branch, mandibular branch, and oculomotor nerve damage. Remember, the oculomotor nerve is that third cranial nerve that affects pupil response to light. But in these places, like the facial nerve originating in the pons, and when it comes out of that stylomastoid foramen, small hole, it almost looks like it's pointing at the ear, but it's not pointing at the ear canal. But a small hole, if that nerve becomes inflamed, infected, injured, then it leads to all sort of facial dysfunction and may resemble a stroke. With trochlear nerve damage, the trochlear nerve comes again right off the pons, and the trochlear nerve is responsible for the superior oblique muscle in the eye, so it's going to cause eye drop. Human and animal bites can occur on the face as well, which would be the result of, or could be significant soft tissue injury from both human and animal bites. And then you have to be concerned too about injuries to the mouth, particularly loose teeth, missing teeth, lacerations, those sort of things. Therapeutic interventions, calming and reassuring, because you can imagine that if you're dealing with a person who has a severe facial laceration, uh, if they're not in, if they don't have a serious life threat, they're probably really concerned about what they're going to look like. So being calming and reassuring, don't let the extent of the soft tissue injury to the face distract you from making sure that the ABCs are taken care of and manual C-spine immobilization is held, um, keeping them in a neutral position until you can do some sort of assessment. Um, they can have airway compromise from soft tissue injuries to the face because of the excessive bleeding and secretions. You may need suction available. I think what we're seeing the trend in severe maxillofacial trauma is that if there are no neurodeficits, then to have them sit up and lean forward. I've dealt with patients where they've got really severe maxillofacial trauma, and you lay them flat on their back, and of course that's not going to work because they're just going to bleed into their airways. Like a gunshot wound to the face, or an extensive face plant into the windshield or into the steering wheel. Um, but if you can sit them up and have them lean forward where they can drain, then that may be a better position initially. We do want to think about intubation. So intubating a seating patient is a challenge, but that's something that we can practice in PHTLS. You want to raise the stretcher of the bed at least 15 to 30 degrees when there is no injury, and that is more for trying to decrease cerebral congestion, trying to decrease a little rise in intracranial pressure. You may have to assist their ventilations, and that may be difficult if they've got a lot of severe maxillofacial trauma. And if they're bleeding, you control that like you do any other bleeding with direct pressure. Can't put a tourniquet on the face or the neck, but so you've got to be firm pressure with your fingertips, packed gaping wounds with a hemostatic dressing, all those things that we talked about. Skill 47.1 is a manual stabilization, and what they're meaning here by manual stabilization is just using your hands to keep their head in a neutral position and encourage them not to move until you can get them completely immobilized in situations where it's warranted. Okay, so here's several different stabilization from behind, stabilization from the front, stabilization when they're supine, stabilization off to the side. And the whole idea is just to keep their head in a neutral position. Stabilization of a standing patient, as you'll see in PHTLS, it's just not something they recommend anymore. That if we've got a person in this situation where they've maybe have some neck or back pain, they've gotten out of the vehicle, they're walking around. The fact that they're up and walking around, chances are pretty good that they don't have spinal cord damage. And rather than doing this and then board them standing, which is something PHTLS doesn't do anymore, just have them sit on the cot. You may consider a collar, that sort of thing. Now we're going to talk about nasal and ear foreign bodies. Particularly in children, there's just about all these different things could end up in their nose. That's pretty much how a child learns, is by smelling and tasting and feeling, and some children just have a propensity to shove things in their nose. So there's beads, pebbles, buttons, toy parts, vegetables, crayons, bolts, screws, sticks, paper, insects, that's another one. And then earwax. Some people do produce quite a bit of excess cerumen, and may need to have that removed from time to time. If not, it can almost lead to a deafness. Some history and physical findings: that you've got a foreign body in the nose of the ear. Might be nose bleeding. If the foreign body is in there and has festered, these people can develop fevers. They can get even septic if gone on long enough. Let's say an insect crawls in somebody's ear and it's not known, but the child has severe ear pain and blood coming out of the ear and a fever and that sort of thing. Purulent discharge, foul-smelling discharge. That's all related to infection. So if you have that coming out of the nose, or you have it coming out of the ear with the addition of decreased hearing, external swelling of both the nose and the ear, an insect buzzing sound, that sort of thing, would indicate a foreign body. We just don't go digging clear up into the nose or deep into the ear in the field. We just don't have the tools to do that. So it's best to be left alone. Get them to a physician where it can be evaluated. The only reason we would attempt to remove something from the nose is if it was compromising the airway. And they're saying one method of doing it is to, close the mouth, block the unobstructed nostril, and have them forcefully blow out and try to blow that obstruction out. Shining a flashlight in the ear may draw an insect out, so that might be something you could do if you think there was an insect in there. Let's look at orbital fractures, or fractures of the orbit. Talking about eye anatomy, there are 7 bones in the orbit. The orbits are cone-shaped. The wide end of the face narrows down as it progresses into the skull, ending at a very small place. The eye is globe-shaped, about 1 inch in diameter. So here's an example of the orbit and a listing of all the different bones that make up the orbit. Again, much larger in the front, and it becomes conical towards the back, where it ends in a very small area where the optic nerve comes in directly from the brain. You've got the eyeball, which is the outside tissue layer. The outside tissue layers of the eyeball include the sclera, the choroid, and the retina. And here's just an example of that. We're all familiar with things like corneal abrasions, things like corneal burns, corneal abrasions, cataracts, those sort of things. And you can see where the optic nerve attaches to the back of the vitreous chamber of the eye itself, and then a optic disc, which goes around the eye itself, and the lens, which is behind the cornea, and then of note would be the sclera, which is the white of the eye, and then the choroid, which is under the sclera, and then the retina, which is the third layer going in. The inner eye is the anterior cavity, where you have the anterior posterior chambers connected by the pupil and the iris. The iris opens and closes. It's kind of like a lens, letting in more light, keeping light out to allow you to see better. The aqueous humor is the fluid inside the globe itself, and that can be regenerated if the eye is injured, and some of that fluid leaks out. It certainly can be regenerated. The inner eye protrudes slightly forward. The posterior cavity is the vitreous chamber, and that's the 80% of the eye is made up of the posterior cavity, or the vitreous chamber. It's filled with vitreous humor, and it cannot be regenerated if injured. The eyeball shape is maintained by hydrostatic pressure exerted by the aqueous and vitreous humor. The iris is a continuation of the choroid membrane. The pupil in the center is the opening to the iris. It's a connection between the anterior and posterior chambers. It allows light and images into the vitreous chamber and comes in contact with the retina. The pupil will constrict and dilate based on the amount of light present, and pupil response is affected by the autonomic nervous system. Medications like any of your beta adrenergic drugs, like even a breathing treatment or epinephrine, will cause pupil dilation. Other drugs, recreational drugs, like narcotics, heroin as an example, will cause pinpoint pupils, those sort of things. The lens divides the anterior from the posterior cavity. It focuses images onto the retinal surface. Myopia is also called nearsightedness. The light focuses in front of the retina, where hyperopia, which is farsightedness, the light focuses behind the retina. Presbyopia, you're unable to adjust from far to near vision, and you can do a visual acuity check following an injury to an eye. There's a process for standing so far away, have them cover one eye with a hand and have them read a line, much like you do when you go in to have your eye exam. An ophthalmoscope is something that you can use to look into the eye to magnify the front surfaces of the eye. You can see the retina. It appears smooth, reddish purple, lined with blood vessels. The optic disc appears yellow. It has very distinct blood vessels at the center with no retina. And if you get an opportunity to pick an ophthalmoscope up and look into the chamber of the eye, it's a pretty neat thing to see. It's something that a person might look at if you're looking for evidence of, as an example, shaken baby syndrome, where you see retinal hemorrhage, those sort of things. The whole purpose of the eyebrows and the eyelashes are to protect the eye and to catch small particles. The eyelids, a major source of eye protection. You've got the lacrimal gland, which is your tear duct, and you have your conjunctiva, which is the soft tissue mucous membrane underneath the eyelids and the eye socket. Now, you can have fractures of the orbit, which involves the bony cavity that the eyeball sits in. You can have what's called an orbital blowout fracture, and that's when the floor of the orbit has been fractured. This occurs from perhaps a direct blow to the eye with a fist or a ball. An orbital blowout fracture, you may have double vision, you may have nosebleeds, pain, soft tissue discoloration, limited ability to look upward. You may have crepitus. You may have the eye may have an appearance of being sunken. The movement of the eyes, you're able to determine which muscle in the eye may be damaged. The inferior oblique controls movement up, superior oblique movement to the bottom, and the rectus, inferior and superior rectus, to the medial up, medial, being able to look down, be down and towards the medial aspect of the face. So the superior rectus and the inferior rectus look towards the nose. Medial rectus, all the rectuses would be looking towards the nose, and the obliques and lateral rectus looking away from the nose. Blowout injury causes muscles, nerves, fat, and connective tissue entrapped by the fractured segment as well. Here is a primary position, right eye lower than the left, which might indicate some sort of orbital fracture. And here's an upward gaze with limited motion of the right eye. That could be an indicator of orbital fracture as well. You're going to manage your ABCs. Blow to the head that fractures the orbit certainly could cause cervical spine injury. But if your patient is awake and can answer questions, then you know that you're going to be able to rule out whether or not you need to spinally immobilize or not. If they're unconscious, obviously, you're going to have to open their airway with a jaw thrust and maintain their airway with an airway adjunct like an NPA or an OPA. Now, I know I just said, ooh, a maxillofacial trauma and NPA, and there's one slide that exists in the medical literature that I'm aware of and have seen on occasion of a NG tube, which is a rather stiff tube and quite lengthy, that was passed up a nose of a person with severe maxillofacial trauma, and it ended up in the cranial vault. So there's this X-ray that you see of this NG tube rolled up in coils inside the head. And as a result of that, that's where that, oh, you can't put anything in the nose of somebody with maxillofacial trauma has. There is no evidence that using an NPA would result in the same outcome. So if that's what is necessary to keep the airway open, then that's what you do. Limited eye movement, indicating perhaps orbital fractures. Maybe cover both eyes with loose bandages to keep the eyes from moving around inside that fractured orbit. Avoid nose blowing, straining, or sneezing. When we look at the anatomy of the nose is there to support the respiratory system. It also has the olfactory nerve, which transmits our sense of smell. It's also important for filtering, warming, and humidifying the air before it reaches the lungs. And it also is responsible for the removal of pollen, dirt, and debris that otherwise would end up in our lungs. You have a right and left nasal cavity in the uppermost part of the respiratory tract. You have a septum that divides the left and right half of the nares. And the floor of the nose is the hard palate. You have other bones that are part of the nose anatomy. The sphenoid and the ethmoid and frontal bones all make up the nasal cavity. The nasal cartilage shapes and support the outer nose. The upper third of the nose is bone, and the lower two-thirds is soft tissue and cartilage. Turbinates are the rippled structures in the back of the nose that cause the air to tumble, and that's where the air is warmed and humidified. And here's an example of the nasal cavity. Here's looking up through the nose, the septum, the septal cartilage, the left and right nare. You can kind of identify some of those structures. The olfactory region of the nose is epithelial cells contain nerve endings and numerous cilia, and molecules from inhaled air pass by or attach and stimulate the olfactory receptors. Chemoreceptors initiate direct chemical reactions, and then the paranasal sinuses include all the sinuses in your face. And here's a picture of the nasal sinuses. You got the maxillary sinuses and the frontal sinuses. But in addition to that, you have the ethmoid sinuses as well, and the sphenoid sinuses. So you have quite a few areas where fluid drains into, and they can be infected, they can be damaged and fractured. If the sinuses are fractured, and the base of the skull is fractured, then you can get a discharge out of the nose, a cerebral spinal fluid coming out of the nose. Now, fractures of the nose, of course, are the most common nose injury and result from a direct blow to the nose. Signs and symptoms of a broken nose: swelling, bleeding, soft tissue discoloration, pain on palpation, crepitus, obvious deformity. You can get hematomas in the nose as well. You can get a septal hematoma, which of course is going to obstruct air flowing through at least one nair, if not both. Treatment for nasal fractures or broken noses include making sure that it doesn't affect the any ABCs. Excuse me. If the blow was significant enough to cause a broken nose, then we certainly should at least assess for and rule out the potential for spinal cord injury. To avoid an obstruction, you may have to provide some suction, unless it's just all soft tissue swelling. If they're primarily nose breathers and they've got an issue with their nose, it may actually affect their ability to oxygenate and ventilate. So you may have to, encourage them to breathe in and out of their mouth. If the nose is bleeding, we control that like we do any bleeding with direct pressure. It's not normal that we would pack the nose. They do make things called rhino rockets, which essentially are tampons that you shove up the nose, and they soak up the blood and expand quickly and help stop the bleeding. But we would provide external pressure, and probably the biggest reason that I see nosebleeds being problematic is that it takes 3 minutes of pressure in order to stop bleeding, and to hold pressure on the nose, that for 3 minutes, that seems like an eternity. So about every 30 seconds or 45 seconds, we're letting pressure off the nose to see whether or not the bleeding has stopped. So we need to put direct pressure for at least 3 minutes, squeezing the soft tissue of the nose, not the bones, not that upper third of the nose, but the soft tissue itself. Have them lean forward, not back, that sort of thing. If you think they've got CSF leaking out of the nose or the ear, cover those with just loose sterile dressings, because that can be advantageous if those fracture sites allow pressure that's building up inside the head to escape. We look at cheeks, the zygomatic bones. You can have cheek fractures, and the zygoma forms the lateral rim of the orbit, and it meets the lateral skull from the zygomatic arch. And there's a picture of the zygomatic bone, and you can have fractures of that as well. Zygomatic fractures are common. I've had one myself from a blow to the face. It can be the result of a motor vehicle collision as well. The left is, for some odd reason, fractured more. And with any broken bone of the face, you have to think about subarachnoid hemorrhage, or at least some sort of brain bleed as well. Zygomatic fracture types include the zygomatic arch, where only the arch is fractured, tripod fractures, where 3 suture lines are fractured, where the zygoma attaches to the facial skeleton. Signs and symptoms: paresthesia of the cheek, facial asymmetry, double vision, soft tissue swelling, discoloration around the eye, pain and tenderness, limited movement of the mouth. You can maybe even palpate a step-off deformity. The globe may look sunken in. There may be facial swelling, CSF coming from the nose. Again, if you're getting CSF coming out of the nose, this isn't just a zygomatic fracture. This is a basilar skull fracture, and the sinuses have to be fractured in order to get CSF to come out of them. Unequal pupil height, crepitus on palpitation, obvious deformity and bleeding. Therapeutic interventions include your ABCs, cervical spine precautions, um, loose bandages covering the eye with limited movement, and whenever you put bandages on both eyes, you make the patient blind. And if you've got injury to one eye, the reason that we cover both eyes, I'm sure as you know, is that when one eye moves, the other one follows. So if we leave one eye open and it's looking around, that injured eye is looking around. So you cover both eyes, but then you've just essentially made your patient blind, and it'd be good to talk a lot to them so they know what's going on. You can have maxillary fractures, which is the upper jaw. Again, you've got a left and right maxilla, and either of those can be fractures. It takes a significant amount of force because these are very large bones, and maxillary fractures are called Lefort fractures. And there are 3 classifications of Lefort fractures. Lefort 1 is from blunt trauma to the mid-face, just below the nose, and it breaks that maxilla away from the face. A Lefort 2 is blunt trauma aimed directly at the face, like a softball to the face, where it fractures not only the maxilla but also breaks away the nose. And a Lefort 3 separates the entire face from the skull. That's quite an impressive fracture to see. I've seen one in my career in an individual who fell quite a distance and landed face first on a rock. And the whole face would move while the skull remained stationary. You're going to get, you're looking at Lefort fractures. You're going to have a patient with severe facial pain, upper lip anesthesia and paresthesias, visual disturbances, facial swelling, conjunctival hemorrhage. The face may appear elongated. You're going to have bruising, swelling of the around the eyes, facial asymmetry. They may have a bloody nose, and then CSF again. Lefort 1 is that horizontal maxilla separated from the skull, just above the palate and below the zygoma. So it's almost like the whole top row of their teeth is broken away. Lefort 2, the central maxilla, the nasal area, the ethmoid bones is where the fracture is. It forms a tripod shape with the nose being the apex. So the nose, the upper lip, no movement of the orbital complex. So you're going to have nose, lip, and eye swelling, subconjunctival hemorrhage, bloody noses. Significant amount of force to do this, so the potential for a cervical spine fracture is there. And then bloody nose with, again, clear fluid or blood-tinged fluid would suggest a basilar skull fracture. A Lefort 3 is a total separation of the head from the face. The nose, the dental arch move without the frontal bone movement at all. Massive swelling, massive bruising, bloody nose, and then malocclusion with a spoon appearance when you're looking from the side. Assess eye movement. If the cribriform plate is fractured, that's the plate up front in the base of the skull that the bone sits on. The middle meningeal artery could be torn, and so you could have a brain bleed. The cribriform plate, essentially the base of the skull, you'd have then a basilar skull fracture. In addition to the broken bones, you can have open or closed head injuries and injuries to the eye itself. And there's just not an example of any sort of Lefort fracture, but an example of some bleeding in the eye. With maxillary fractures, C-spine precautions, make sure that you maintain a patent airway. That's a really high priority because of all the soft tissue swelling. A lot of bleeding, so it may require frequent suctioning. You may have to intubate these patients because you definitely don't want to lie them flat if there's a lot of swelling and bleeding. Ice packs to the face may decrease the swelling somewhat. Mandibular fractures include the lower jaw, and the mandibular body is anterior, where the mandibular ramus is posterior. The body and the ramus meet posterior and form the mandible angle, or the angle of the jaw. So the ramus of the mandible is vertical, where the body of the mandible is horizontal, and they meet together to form the angle of the jaw. Mandibular fractures can be caused by blunt trauma from domestic violence and sports, penetrating trauma from gunshot wounds, blast injuries, industrial injuries. Most common is the mandibular angle, or a condyle, or molar or mental symphysis fractures. Reciprocal fractures can occur on the opposite side of the mandible, kind of like coup contra coup injuries. The bottom set of teeth is attached to the mandible, so you could have teeth malocclusion, jaw curvature, misalignment of the bottom set of teeth, point tenderness, crepitus, step-off, deformity. You could have trismus, which is their jaws locked shut. Obviously, facial asymmetry could occur. Inspect the mouth and for loose teeth and for sublingual swelling and hematomas. And again, if the force is significant enough to fracture the mandible, then look for signs and symptoms of a skull fracture as well. Manage the ABCs, consider C-spine immobilization, suction bone fragments, blood clots, vomitus, to keep the airway open. Dental trauma has to do with teeth. Children have 20 primary teeth. They erupt at about 6 months to 2 years, and then they get their permanent teeth from 6 to 14 years, and their wisdom teeth come in between 17 and 21 years. The adult ends up with 32 permanent teeth, 28 if the wisdom teeth have been removed. Tooth anatomy, it's attached to sockets in the bone arches of the maxilla and the mandible. Your gums are a specialized oral mucosa, which attached to the base of the teeth. The crown is the visible tooth part that we see, and it's covered with enamel. The neck of the tooth connects the crown to the root, and the root extends into the maxillary and mandible. It anchors the tooth. You've got 1 to 3 roots per teeth. The cementum anchors roots to periodontal membranes and ligaments. The pulp is the soft tooth center. That's where your nerves and your blood vessels and your connective tissue. It's highly vascular, very sensitive nerve endings, and that's where dentin is produced. Now, if you've had any sort of toothache in the past, or have had to have a root canal, you know how painful those nerves could be. In addition to being highly vascular, they're very sensitive nerve endings. So here's a picture of all that: the crown, the neck, the root, the pulp, and the root canal. So when they do a root canal, they go in and strip that nerve out of there so that there's no more pain. Teeth can be fractured. If it just involves the dentin, it's mild discomfort, but if it involves the pulp, it can be significantly painful. Deep fractures involve the root as well. If you've got a tooth that's been avulsed out of the mouth, look for the tooth. It could be replaced. A dentist may be able to replace it so that it is salvaged. Because there is a significant blood supply to those teeth, then it's important that you assess for bleeding inside the mouth. If you have teeth that are knocked out, again, it's a significant mechanism. Assess for the potential for spinal cord injury as well. Dental trauma peaks at ages 2 to 5. Men are twice as often to have dental trauma than women, again, because of all the stupid things that we do. Sports, fights, family violence, those sort of things. Eye trauma, you can have corneal abrasions, corneal lacerations, foreign bodies, even rubbing the eyes too vigorously, particularly in patients who've had cataracts or those sort of things, can cause problems. So you want to get a good, as far as corneal abrasions and lacerations, you want to get a good history and assess the eye. Corneal abrasions and lacerations involve only the eyeball. With a corneal abrasion, if it just involves only the eyeball, the eye itself is going to be reddened and sore. There'll be burning in the eye, pain when they close it, almost like they've got sand or gravel in their eye, particularly when they close it and move it around. They're sensitive to light. They may have a decrease in visual acuity. Very large corneal abrasions require surgery, but smaller ones are treated with some ointments and a patch. Cover the eyes, transport to an ophthalmologist. Burns to the eye can be thermochemical or even ultraviolet. Most are pretty superficial because the cornea is there and the cornea may get burned a little bit. The one thing about the eye is that injuries to the eye heal quickly because there's such a vascular supply to the eye itself that corneal abrasions often will repair themselves in 24 hours. Most common is a chemical injury to the eye. 15 to 20% of all ocular injuries. The majority are work-related. Thermal is the second most common damage to the cornea itself. If you've ever watched welding without welding goggles, you look at that for any length of time and it'll cause ultraviolet burns, or if you're out in the bright sunlight up in the mountains without proper cover, you can actually get ultraviolet burns to the cornea. Chemical, the most damaging type of burns to the eye, can end up in vision loss. In addition to that, a potential for facial skin burns. Acid burns will cause epithelial cornea damage, and depending on how long the acid is in there, and will determine the amount of damage that's done. And acids are corrosives, but bases will do the same thing. Strong bases like lye and those sort of things in the eye will cause chemical burns to the eye itself. And here they're talking about alkaline substances. They will emulsify the tissue. They include things like lye, drain cleaners, and they will continue to damage the eye until they're removed. May cause permanent scarring, which would lead to vision loss. Ultraviolet burns come from sun, unprotected welding. They're very painful. They cause the eye to tear, photophobia, so they become very light sensitive, and you have a feeling that there's a foreign body in your eye, but there isn't a foreign body. It's just the cornea itself is burned, and as it rolls over the eyelid, it feels like there's something stuck in there. Flash burns are an unshielded exposure to a welding arc or an explosion may cause temporary blindness. As a result of overstimulation of the retinal surfaces, there also may be corneal damage. Therapeutic intervention for burns to the eye caused by acids or alkali. Flush with lots and lots of water. Control pain if they're having a lot of water. Use either saline or Ringer's lactate. And here's a Morgan lens. And a Morgan lens is an awesome device to flush the eye, but certainly if you don't have something like that, I'm sure Ray or Cherry can remember the trick of using a nasal cannula in the eye in order to irrigate it. Here they're talking about the skill of attaching a Morgan lens. So there's one Morgan lens in that eye, and they're working on putting another Morgan lens in the other eye. And here they did 2 hours of flushing over about a liter for each eye. You can have eyelid lacerations. They can be superficial or full thickness. And you can certainly identify it just by looking. I mean, you know when an eyelid is lacerated. They should see a physician, control hemorrhage, irrigate with saline, sterile dressing, eye patch. Corneal foreign bodies, a scratch of the cornea, and this you'll know this because when the eye is exposed to light, it's very painful. It may feel, or they may describe it as a burning sensation. And when they close their eyes and move it around, the pain is often increased. If they have a foreign body stuck in their eye, when you shine your pen light, the object may show up as a dark shadow. If it penetrates the eye into the anterior chamber, you can there's a potential for the vitreous humor to leak out. Corneal foreign bodies, we don't remove those in the field. We want to stabilize them if at all possible, and flush the eye with clear fluid. Hyphema is a rupture of the iris. Comes from direct trauma to the globe. Incidence about 2 in every 100,000 people may experience this. Those at greater risk of this include the elderly and younger patients. Hyphema may occur also in African Americans with sickle cell. To see it, shine a pen light from an angle through the anterior chamber. In doing so, if they have photophobia, pain, blurred vision, droopy, drowsy eyes, also assess for rupture of the globe by looking at the position of the eye in the socket and whether it can move up, down, left, or right. Spinal precautions for hyphema. Again, any sort of injury to the face significant enough to cause these things, you should be assessing for the potential for spinal cord injury. The patient should not cough, strain, anything that would increase intraocular pressure. When lying them down, blood changes position and blurs their vision. So they need to be transported, and after being assessed, if the blood does remain in there, it will reabsorb into the body over time. Penetrating globe injuries, traumatic vision loss, it can occur in an industrial setting when you're not wearing protective eyewear. Blast injuries, stab wounds, gunshot wounds, eyelid lacerations may also penetrate the globe. If you've got an embedded object or a laceration of the eye, there's a potential for the globe itself to be perforated or ruptured. When you've got that impaled object, do not remove it, stabilize it, cover both eyes. If you've got a ruptured globe, cover both eyes, try not to put any pressure on the globe, and if the patient's vital signs support it, certainly anybody in a lot of pain, we can give pain medications, whether it be morphine or fentanyl, and then transport. Retinal detachment is when the retina separates from the eye choroid. The patient may have myopia, eyeball elongation. We see retinal detachments in patients with high blood pressure and diabetes. It can also be caused by blunt or penetrating trauma. May cause that separation. It's seen more in people 40 plus years, men in white. My brother-in-law, my boss's husband, all would fit that, over 40, white. Not sure on the high blood pressure or diabetes part, but you throw those things in there, and somebody sees floaties. That's the most common thing they'll describe with a retinal detachment, is that they see these things floating in their eye, and treatment is interesting. Vision changes, possible loss of vision, bright flashes in the visual field, curtain coming into the visual field, or a curtain that closes over the eye, makes it hard to see. This requires rapid treatment to prevent permanent blindness. Mobilize your head, cover both eyes, transport him to an ophthalmologist. Traumatic iritis is an iris inflammation from blunt trauma. The eye will be reddened. The pupil may be distorted. They may have eye or brow pain, be sensitive to light, may have excessive tearing. Again, not much we're going to do other than get them to a physician to be evaluated, and if they're in severe enough pain, give them something for their pain. Alright, with that we're going to go ahead and stop with the discussion on head and face trauma, and I'll be talking to you soon with part 2, where we'll continue with ears and the rest of the head.